Welcome to this presentation of Towards a Gendered Understanding of Women's Experiences of Mental Health and the Mental Health System, an issues paper published by Women's Health Victoria. To begin, Women's Health Victoria acknowledge the traditional owners of the lands our offices are on, the Wurundjeri people of the Kulin Nation. We pay our respects to their elders past and present. Women's Health Victoria recognises that sovereignty has never been ceded, and that as we are the beneficiaries of stolen land and dispossession, we have a responsibility to fight for Aboriginal and Torres Strait Islander rights, justice, and self-determination. Women's Health Victoria is a health promotion, policy, advocacy, and support service that advocates for women's health and equality. Our priority areas are mental health, sexual and reproductive health, and women and cancer. On this side, you can see our various sub-brands. And I draw your attention to the Women's Mental Health Alliance logo down the bottom. Women's Health Victoria convened the Alliance in 2019 in response to the lack of attention given to gender by the Royal Commission into Victoria's mental health system. Since then, we have grown to over 40 members, including people with lived experience, clinicians, researchers, mental health services, and women's health and community service organisations. With gender left out of the terms of reference of the Royal Commission and only referred to briefly in the final report, we focused our attention on making sure the implementation of the reforms has a gendered lens and will benefit women, girls, and trans and gender diverse people. In addition, Women's Health Victoria is a member of many consultation bodies, including the Victorian Government's Mental Health Ministerial Advisory Committee and Safer Care Victoria's Improving Sexual Safety in Mental Health Inpatient Units project. If you would like to learn more about the mental health policy work of the Alliance and Women's Health Victoria, please scan the QR code shown. We have produced a range of papers, delivered webinars, and written numerous submissions for both state and federal consultations, all available on our website. So with that context, now let's turn our attention to Women's Health Victoria's paper, Towards a Gendered Understanding of Women's Experiences of Mental Health and the Mental Health System. You can download the paper via the QR code on screen. Work on this paper was prompted when Women's Health Victoria identified a gap in the literature on the case for a gender-responsive approach in mental health, hampering our and others' advocacy on this important issue. So we began gathering evidence and case studies that demonstrated what the problem is and why a gender-responsive approach is needed in mental health. Drawing on research, data, and the voices of Australian women with lived experience of mental ill health and the mental health system, the paper highlights the ways in which gender unequal norms, practices, and structures influence mental health risk factors, diagnoses, treatments, and access to and experiences of mental health services for women. With a focus on the Victorian context, it highlights how the building blocks of policy settings, funding, workforce, research, and data collection can all contribute to and reduce gender inequality. Towards a Gendered Understanding is not intended to be a comprehensive evidence review, but rather a snapshot of how gender inequality plays out in mental health. We will soon be publishing a companion paper identifying ways forward for gender-responsive mental health care, health promotion, and primary prevention. Keep an eye on our socials and website to find out when this is released. This presentation is in 4 parts and mirrors the paper. First, we'll look at why a gendered approach to women's mental health is needed. Part 2 explores the biological and social determinants of mental health for women. Part 3 goes into the influence of gender and sex on mental health diagnosis and treatment. And Part 4 delves into gender and the mental health system. In the first section of the paper, we show how sex, gender, and gender inequality influence not only the drivers of mental ill health in women, but also their experience of the mental health system. For instance, Australian data show that mood disorders are twice as prevalent in women as compared to men, and that women are twice as likely to be hospitalised for intentional self-harm. In addition, we know that 95% of hospitalisations for an eating disorder are for females. At least 1 in 5 pregnant women and new mothers experience perinatal anxiety or depression, and females represent the majority of people seeking mental health support and services in Australia. And so, while not exhaustive, these statistics make a compelling case for taking a gendered approach to mental health. Different groups of women and girls also experience poorer mental health outcomes than the general population, a reflection of the intersections between gender inequality and other forms of inequality and discrimination. For example, psychological distress, self-harm, and suicide rates are significantly higher for Aboriginal and Torres Strait Islander women compared to non-Indigenous women. Women and trans and non-binary people from the LGBTIQ+ community face higher risks of mental ill health compared with cis heterosexual women, and are almost 4 times as likely as their cis or heterosexual peers to have tried to self-harm or suicide. Migrant and refugee women experience higher rates of perinatal anxiety and/or depression than Australian-born women. So what's behind these concerning statistics? And why do women's and men's mental health outcomes differ? In the second part of our paper, we shed some light on this question. We unpack some of the key biological and social factors that influence women and girls' mental health throughout the life course, both independently and in combination. Biological factors related to sex mean that women may experience specific mental health conditions linked to their hormonal systems and reproductive capacity throughout the life course, such as premenstrual dysphoric disorder. Genetics can also play a role. There are also sex differences in the impact of early childhood trauma on the brain. Significant social risk factors for mental ill health include discrimination, gendered violence, and socioeconomic disadvantage. All of these impact women, girls, and trans and gender diverse people at higher rates than men. The biological and social determinants of mental health also intersect, and many mental health conditions affecting women arise from a combination of biological and social factors, as the examples on the slide illustrate. Making matters more complex, women's mental health is impacted by the cumulative experiences of gender inequality, discrimination, and reproductive and life stage elements across the course of their lives. Taking middle age as an example, Australian mental health outcome data for women tell us that the highest proportion of suicide deaths in women is in the 45 to 49-year age group. Recently, rates of very high psychological distress more than doubled for women aged 55 to 64, from 3.5% to 7.2%, with women on lower incomes experiencing greater distress. And an increasing proportion of middle-aged women are consuming alcohol at risky levels. Behind these statistics, some of the factors negatively impacting middle-aged women's mental health are unpaid caregiving and role strain, as women in this age group are more likely to be providing unpaid care to children, parents, and/or partners while balancing paid employment. Caregiving can intensify for those in their mid-50s to mid-60s, often related to a partner with a serious medical condition. Another factor is experiencing troublesome menopausal symptoms while navigating the challenges of this life stage. In order to relieve this stress, many women report using alcohol. As we touched on already, violence against women is one of the most common causes of poor mental health. Indeed, the World Health Organization considers violence to be the principal gender-related cause of mental health problems among women. In terms of mental health outcomes, Women who have been abused by a partner, for example, are 3 times more likely to suffer depression, anxiety, or severe conditions such as schizophrenia or bipolar disorder. However, the links between women's mental ill health and experiences of gender-based violence are poorly recognised and understood. And within the mental health system, particularly when care is heavily influenced by the biomedical model, there is a tendency to pathologise what is a rational response to trauma. This approach effectively turns a social problem into an individual dysfunction. The effects of the under-recognition of the impact of gender-based violence on women's mental health reach beyond the mental health system and include the justice system. Raising the issue of mental health in family court matters is gendered. For example, where child contact with mothers is limited, mental health is given as the reason in 30% of cases, as opposed to only 2% of cases limiting child contact with fathers. The extent of co-occurring family violence and mental health problems underlines the importance of prioritising family violence as a health and mental health issue, and the need for a more coordinated efforts to strengthen health system responses. More broadly, measures to promote gender equality by helping reduce rates of gender-based violence are critical for primary prevention of poor mental health and well-being in women and girls too. There is a lot more work to be done on this. Cross-sectoral action around the impact of domestic, family and sexual violence on women's mental health continues to be sorely needed. In the meantime, if you are interested in learning more, the 2020 ANROS paper referred to on the slide is excellent. The third section of our paper moves on to look at the way gender influences how women's mental health is understood, diagnosed and treated, and women's experiences of the mental health service system. To give some context to this, let's first have a deeper dive into gender inequality and how it is expressed and maintained in society through the interaction of gendered norms, practices, and structures. We'll use mental health as an example. Gender norms refer to values, attitudes, and beliefs that construct masculinity, femininity, and binary gender difference. Examples of this are norms that construct men as rational and stoic, and dismiss women as emotional and unreasonable. Gender norms intersect with other social norms and stereotypes which shape the health and well-being of different groups of women and their experiences of the mental health system. Gendered practices are behaviours that reflect the internalisation of gender norms by individuals, groups, and institutions. These practices reinforce gender inequality and gendered power dynamics, often playing out in interpersonal relationships. Gendered structures formalise gender inequality and the way power and resources are distributed in society, including legislation, policy, and funding. Gendered structures can be direct, for example, the underrepresentation of women in leadership positions, or indirect, like policy and programs that do not account for gender differences. These all overlap. To put all this together, one of the starkest examples of the intersections between gendered norms, practices, and structures is the long-standing failure to protect women from sexual violence in mental health inpatient units. This has been despite decades of advocacy by women with lived experience for their right to be safe when under medical care. This gendered practice arises from attitudes that blame women for and/or excuse men for sexual violence and do not prioritise women's safety. It also reflects gendered structures insofar as resources to promote women's safety in mental health inpatient units have not been allocated. The failure to allocate resources for single gender units in turn reflects gender norms that, as noted by the Royal Commission, deem it women's responsibility to manage male aggression and violence, and which prioritise economic efficiency over women's safety. Positively, in 2021, the Victorian government accepted a recommendation from the Royal Commission to address gender-based violence in mental health facilities and work to ensure mental health inpatient facilities enable gender-based separation is underway. This includes allocating resources to the Victorian Health Building Authority and Safer Care Victoria's new Improving Sexual Safety in Mental Health Inpatient Units project. The Safer Care Victoria project, however, recognises that physical spaces will not improve safety alone. The service model, operational policies and procedures, and trained and resourced staff are key to improving human rights and safety in mental health inpatient facilities for women and other at-risk cohorts. Now let's turn our attention to some of the ways that gender inequality shapes women's experience of the mental health system, from diagnosis to service use. The prevention of mental ill health and the promotion of mental health and well-being are vitally important parts of the continuum of the mental health system. However, they are not the focus of this paper and will be explored in our next one on promising practice in gender-responsive mental health. Let's look at diagnosis. Entrenched gender bias within the world of medical research and education means that our understanding of mental health conditions is based on a male model. However, women and girls experience different risk factors or may present with different symptoms, which, due to the lack of research attention, may not be recognised by mental health professionals or women themselves. Despite clear evidence of how gendered experiences influence women's mental health, the biomedical model remains dominant within Australia's mental health system and research literature. If used in isolation, this model ignores the social causes and contexts of women's distress. As mentioned earlier, an exclusively biomedical approach to diagnoses treats women's responses to these stresses as psychologically abnormal, locates systemic or social problems in the individual, and can exacerbate trauma and compound its effects, including beyond the mental health system, as we saw in the example about the family court. Prevalence of gendered attitudes and stereotypes mean women's experiences may be dismissed. For example, women who attempt suicide may be described as attention-seeking or manipulative. And women are overrepresented among those with the most stigmatized diagnoses. For example, 75% of people diagnosed with borderline personality disorder, or BPD, are women. This diagnostic label suggests that there is something wrong with their personality, but what is missing is the fact that BPD is also the diagnostic category most strongly associated with childhood sexual abuse. In fact, 85% of women with BPD have experienced significant early life trauma. Some have called for this condition to be renamed complex trauma disorder. Now let's look at treatment and service models. Most services designed to address mental health take an individual pathology perspective, whereas the women who need these services consistently ask for a more holistic view of their lives. The exclusion of women from clinical trials means that medications have largely only been studied on men and may have significant and unacceptable side effects for women. For example, despite women experiencing more severe side effects from psychotropic medications, such as greater weight gain and cardiovascular and metabolic side effects, mental health clinicians are largely unaware that side effects are sex-specific. And as noted earlier, there is a limited understanding of the impacts of gendered violence and trauma on mental health. And, as mentioned before, women often feel or are just not safe when accessing mental health services. Seclusion and restraint resemble and replicate many women's experiences of past abuse and traumas, including sexual violence. Survivors of family violence report experiences of inpatient settings that include being forced to take their clothes off, being forcibly medicated, and at times restrained. Victim blaming has been reported as an issue for women who are seeking help for complex post-traumatic stress and anxiety following experiences of violence. And pre-service education for mental health professionals rarely includes discussions of sex or gender differences. Long-term trauma recovery is part of the spectrum of mental health care and is especially important for victim survivors of domestic, family, and sexual violence. However, there is a lack of focus and action on long-term trauma recovery in Victoria and Australia. Adequately supporting trauma recovery via an appropriately skilled and resourced mental health system, working in concert with the family violence and sexual assault response service systems, is an important step towards reducing women's higher prevalence of PTSD, BPD, and other mental health diagnoses. But there is promising practice. In Victoria, our new statewide trauma service is partnering with the Women's Recovery Network's Hospital in the Home service to build capacity in and advance trauma-informed care for women. Federally, the second National Plan to End Violence Against Women and Children includes a new and welcome commitment to address recovery from violence. In her evidence given to the Royal Commission into Victoria's mental health system, Sandra said, "I was made to feel the way that I functioned and was surviving was wrong or a problem, rather than as an understandable response to what I have experienced." This quote shows how the biomedical model, lack of understanding of women's mental health, and the impact of gendered violence, combined with gendered stereotypes, shaped Sandra's experience of mental health care. The final chapter of our paper addresses gender and the mental health system. Here we look at the building blocks of the mental health system, sometimes described as system enablers or barriers to gender equality. First up are policy settings. Policy settings can be a foundational enabler of or barrier to gender equality in the mental health system. They create the authorising environment for prioritising gender equality and include policy settings in mental health as well as other areas of government. In Victoria, there has never been a more important or opportune time for a stronger focus on women's mental health due to the mental health, family violence and gender equality reform landscape. In 2021, the final report of the Royal Commission into Victoria's mental health system emphasised the need for safe, culturally responsive and trauma-informed mental health services. And although not explicit in the Royal Commission's recommendations, the early stages of implementation acknowledge the need for a gender lens on the reforms. And the new Mental Health and Wellbeing Act includes gender and cultural safety principles, which means that services will be required to consider gender safety needs. During Victoria's Mental Health Royal Commission, there was a missed opportunity to build on the findings and recommendations from the Victorian Family Violence Royal Commission, despite the known intersections. Since the Family Violence Royal Commission, public mental health services are required to incorporate the Multi-Agency Risk Assessment and Management, or MARAM, framework into their policies and practices to assist in identifying and responding to family violence. Unfortunately, there's been low take-up of MARAM training in public mental health services to date, and private mental health services are not required to adopt MARAM, even though that they see an estimated third of consumers. And at a national level, the new National Plan to End Violence Against Women includes recognition of the need for long-term trauma recovery. A final area of policy that significantly and positively influences some of the social determinants of women's mental health is gender equality. In Victoria, we have the Safe and Strong Strategy and a Gender Equality Act. Under the new gender equality legislation, public sector organisations in Victoria, including health services, are obliged to ensure that their workplaces and services are gender equitable via the implementation of gender equality action plans. There is clear evidence that the mental health system and workforce are not currently equipped to deliver gender-responsive, trauma and violence-informed care to women. There is a significant need for cross-sector capability building between the mental health, family and sexual violence response sectors. All staff delivering mental health services must be adequately trained to respond to issues of intersectional disadvantage and compounded mental health issues. This includes on the impacts of family and sexual violence and the consequences of structural and systemic discrimination in the lives of women, girls, and trans and gender diverse people. Also under workforce are staff attitudes and behaviours. Women receiving mental health care report being made to feel that they are difficult to care for, victim-blamed, or misdiagnosed. These negative attitudes towards female consumers have resulted in staff not taking sexual assault disclosures seriously, minimising or blaming consumers. Gendered expectations and stereotypes can also influence staff decisions about using restrictive interventions. For example, expectations about appropriate emotional expression and behaviour for women, and about the motivations behind women's behaviours. Then there's the need for system and cultural change. On their own, workforce training and capability building are insufficient to embed new ways of working, address entrenched attitudes, and dismantle harmful and discriminatory practices and structures. Workforce development must be accompanied by whole-of-organisational approaches, driven by senior leaders, and be adequately resourced to support staff to learn and adapt. There need to be changes to training and education to improve understanding of how women's mental health concerns are distinct from men's. Currently, pre-service education for mental health professionals rarely includes discussion on sex differences, let alone gender differences. The mental health system and its workforce must also reflect on structural barriers and entrenched biases, a shift in focus from the marginalised to the marginaliser. And leadership within the mental health workforce is a gendered issue. The growing number of women choosing to become psychiatrists has not led to an increase in the number of women in leadership positions. For example, 45% of Royal Australian and New Zealand College of Psychiatrists members are female, yet women hold only 21.5% of clinical director positions and 20% of senior academic positions. While more funding does not necessarily equate to improved outcomes in mental health, key areas where adequate resourcing has important impacts, particularly for women and girls, include better pay and conditions for the mental health workforce. Improving pay and conditions also involves replacing short-term funding with ongoing funding to enable employers to offer ongoing employment, and will assist in addressing the negative perceptions associated with working in mental health by making it a more attractive field. Under-resourcing also contributes to much of the stigmatisation and poor human rights outcomes for mental health consumers that arise through interactions with mental health workers. To avoid using traumatising and coercive interventions, mental health workers need resources including time, training, and enough colleagues on shift to work through alternative approaches. Governments and services also need to make the necessary investment into gender-separated mental health inpatient units, which is currently underway in Victoria. The final mental health system building block this paper considers is research and data collection. From prevention to recovery, investment in mental health should be guided by evidence. Failure to centre the consideration of sex and gender in mental health research contributes to gendered inequalities in mental health experiences and outcomes, inadequate understandings of women's health needs, and ineffective interventions. But there is limited evidence about effective gender-responsive interventions for women, trans, and gender-diverse people. This highlights the need for significant investment in building the evidence base here. To support a better understanding of the mental health needs, experiences, and outcomes, data disaggregated by sex and gender should be collected, publicly reported, and analysed. And there are so many opportunities for the Victorian government to pioneer this research, including via the Collaborative Centre of the Mental Health Reforms and Transforming Trauma Victoria. To conclude, today we have unpacked some of the multiple overlapping ways in which gender and gender inequality influence the mental health and well-being of women and girls. It is clear that the mental health system needs an approach that is intersectional, gender responsive from the policy level to service provision, trauma and violence informed, and also encompasses the life course. Women, girls, and trans and gender diverse people deserve a public mental health system that isn't designed around the needs of men, steeped in gender bias, and which too often devalues and dismisses their concerns and experiences. So what would a better mental health system look like? We think it would recognise that mental health is influenced by both sex and gender, centre the insights of women, trans and gender diverse people with lived experience of mental illness through co-design, prioritise primary prevention of mental ill health, in short, it would tackle gender inequality, remove the gender bias in research, have a well-remunerated mental health workforce, and authorising policy settings would make all of this possible. Follow Women's Health Victoria through our news and social media for information on our next issues paper, due in early 2025, which looks at promising practice in gender-responsive mental health care. If you would like further information, you can download our paper or send us an email. Thank you for listening today.